So this is quite an interesting question. Let me see how you thought about this. 60-year-old man has a gastric outlet obstruction after corrosive injury. Normally, when there is a corrosive injury, there is problem in the esophagus. Sometimes the acid goes all the way down and it can cause gastric outlet obstruction because of pyloric edema. Patient is not tolerating oral feeds. You have to give some kind of nutritional support, some artificial nutrition will have to be given. What will be the most appropriate modality? Can I give a Ryle's tube or a nasogastric feed? This obviously will not work in GOO. If there is a gastric outlet obstruction, you obviously can't do gastric feeds, right? He will continue to vomit. So you have choice. Should I give feeding jejunostomy or a TPN? Both are okay, but remember the thumb rule. Wherever possible, you should always prefer enteral nutrition. GIT feeds will always be better over TPN. And here there is a problem at the gastric outlet, which means I can give feeds into the jejunum. I can do a feeding jejunostomy. Okay, so the answer here will be option B, feeding jejunostomy. What is this Witzel technique? I will show you what this is. It's quite a simple thing to do. We surgeons do it quite routinely. Now understand, when I'm doing putting a feeding tube either in the stomach or in the jejunum, one of the ways of putting it is I directly make a hole in the organ, whether I'm doing a gastrostomy or a jejunostomy, and I will put the tube directly inside. But the problem is, through the hole when I put the tube can sometimes migrate, it can get displaced. So what I do is, I make a hole, put the tube inside of a significant length, and I take seromuscular sutures to keep the stitch in place, to keep the tube in place. So I'm going to take these seromuscular sutures. Seromuscular means bury the serosa and the muscularis and put the tube inside it so that the chances of it getting displaced are very less. This is called as Witzel technique. Okay, this is called as Witzel technique. It is just a technique where you're taking these seromuscular stitches so that the tube does not get displaced. So the answer here will be feeding jejunostomy. These are the kind of questions that kill us in the exam. They seem very obvious on the face, but in the exam, in the stress, sometimes we make mistakes because our mnemonics fail us. So here you don't even need any mnemonic, you just need some common sense. Now look at this question. It's based purely on common sense. You are doing a hepatico-jejunostomy, means you are joining the bile duct, the hepatic duct to the jejunum. Maybe you did a CVD exploration, or maybe as a part of Whipple's procedure, it doesn't matter, but you're doing a HepJ. And when you're doing the anastomosis, you are choosing a monofilament suture. Which of these is most appropriate? Now, surely you would have mugged up the monofilament sutures. So a vicryl is polyfilament. So you will think maybe it's chromic catgut, PDS, proline, I don't know which one. And then you will do some eeny, meeny, miny, mo. Let's not do that. It's a common sense question. You are doing a bile duct anastomosis. Whenever you are doing any biliary or urinary anastomosis, like you are doing a surgery on the urinary bladder, will you choose a suture that will remain forever or which is absorbable? Obviously, you should use a absorbable suture. Because if the suture remains in place forever, it will be a nidus for stone formation. So whenever you're doing biliary or urinary anastomosis, you will never choose non-absorbable, means you cannot choose proline or nylon, you are going to choose PDS. Okay, chromic catgut has a very limited role in general surgery today because it gets absorbed a little too fast. It will get absorbed in 10 to 14 days. So I don't use it in any important place. Sometimes nowadays we use it for a stump of appendicectomy or in circumcision, that's it. But conventionally in GIT nowadays, we will use PDS if we want something delayed absorbable. So best answer here is going to be PDS or polydioxazole sulfate for a biliary anastomosis, right? Be very watch out for these kind of questions. They come in the exam, they seem very easy, but they are using your common sense. This is a nice tricky question. Patient presents with a intermittent abdominal pain and a soft mobile periumbilical mass. So there is a lump in abdomen. It's around the umbilicus in a 25-year-old. And what is it showing classically? It is showing mobility perpendicular to the root of the mesentery. So if my small bowel, let's assume this is my small bowel. Small bowel is kind of oriented like this in the abdomen. And the route of the mesentery will be like this. This is the mesenteric attachment. You know, it goes from the DJ flexure towards the right sacroiliac joint. This is the route of the mesentery. Any mass which is moving perpendicular to the root of the mesentery, means in this direction, is likely to have an origin of the mesentery, because mesentery will only move like this. It cannot move where it is attached. It will move perpendicular. So I'm telling you, it is moving perpendicular to the mesenteric root. It is a cystic lesion between the layers of the mesentery. So what is the lesion? It is likely to be a mesenteric cyst. Most likely or most common mesenteric cyst, it is called as chylomlymphatic cyst. Okay, it is called as chylomlymphatic cyst. Now you will say, sir, even omentum is like mesentery. Why is it not an omental cyst? Omental cyst will move in all directions. Okay, it will have nothing to do with mesenteric attachment. It will move in all directions. Lymphangiomas are usually multilocular. Okay, not a unilocular cyst. They are usually multilocular. Pseudocyst of pancreas obviously will be immobile. Right. And this finding, let me tell you, mobility perpendicular to the direction of mesentery, this is given a name. It is called as Tilloch sign. There is a Tilloch triad. This is called as Tilloch sign. The lump moves perpendicular to the direction of the mesenteric roots. Right. So this is a mesenteric cyst. Remember, they look like this. They are of two types. The most common type is chylomlymphatic, which is arising in the mesentery directly. It has a lymphatic origin, and the treatment of chylomlymphatic cyst is enucleation or excision. You just remove it. It has its own blood supply. But the other one, little less common, are enterogenic cysts. They are kind of having some connection to the bowel wall, and they share the blood supply with the bowel. Treatment of enterogenic cyst will be, you will have to resect the cyst along with the adjacent bowel. You will have to do a resection and anastomosis of the adjacent bowel. So these are topics which are infrequently asked, but you should know a little bit about them because the questions are going to be very easy. They love asking these questions. It's one of the famous exam topics, whether you are giving NEET or INI or FMG exams. So patient develops bile leakage after a lap chole. So they are telling you straight away there is a bile leak because the abdominal drain is showing bilious fluid. Patient is stable. Stable means there must not be a very big bilioma. Maybe the leak is not a high volume leak, probably. Now, what is the imaging showing? The leak is from a small duct in the gallbladder bed. Now, you would have studied Strasbourg and you would have remembered type A leak, cystic leak. Type B leak, there is a blockage of right posterior. Type C, there is a leak or a cut of the right posterior. D leak, lateral injury to common hepatic. None of this is coming here. And there is one option, type E. What is type E? Type E is transaction of CHD. That is also included in Bismuth's classification, transaction of common hepatic duct. This can present acutely, but normally it leads to stricture of common hepatic duct. Nothing of that seems to fit in the question. So what is the answer? Remember, type A is not only cystic leak. Type A is going to be cystic leak, which is the most common type, or it can be a leak from some smaller bile ducts. So even smaller or aberrant bile ducts in the vicinity of the GV fossa near the cystic duct is also Strasbourg type A. Right, so answer here will be Strasbourg A, and I will show you. Look at this image. This is the image from Bailey. Look at type A. It can be cystic leak, or it can be some branch of some small bile duct. This is right anterior. This is right posterior. It is not leaking from right posterior. It is leaking from some small duct near the right posterior. So that is also going to be Strasbourg A only. Okay, Strasbourg C is right posterior leak directly, and Strasbourg D, I told you, is a lateral injury to common hepatic duct. So as you are going up the Strasbourg ladder, the severity of leak is becoming more and more. That is the concept of Strasbourg's classification.